Also, I think Dr. Ichhapure is right now in an ICU, so we can start with his introduction, and once he's back, then we can introduce him again.
Yeah. Now is it visible?
Yes,
Yes.
ma'am, you can go ahead. Thank you.
Thank you. So we have Dr. N.R. Ichapuria, who is the basically brain of this entire workshop. So he's the program director for No Thrombosis. He's done his MBBS, MD Medicine, and DM Neurologist. He's currently a director in neurology in Sayadri Hospital, Yerwada. He was the first one to start neuro ICU and neuro intensive care of Pune. He has been a pioneer in the thrombolysis treatment for stroke in India. He has more than 300 public lectures and workshops on stroke. He has been a member of Indian Stroke Association and the organizing president of StrokeCon 2012. He has also been the organizing president of ISA's Stroke School. He has been a founder of the Pune Stroke Group, and he has also been ex-president of the Society of Neurosciences, Pune, and Maharashtra Academy of Neurology. He has also been a principal investigator for many multinational stroke trials like Perform, Brainscape, BG12, cortical venous thrombosis, Interact, etc. And he has also been awarded as health icon by the Times of India Group. This was our program director. Now let's move to our moderators. The first moderator being Dr. Brigadier S.P. Gorti, who has done his MBBS, MD, DNB, DM, FAAN, NCE in Neurology UK. Currently, he is the professor and head of neurology unit at Bharatiya Vidyapit Medical College, Pune. His areas of interest are stroke movement disorders and stem cell research, and his major achievements was ML Soni Award for Best Resident in Neurology AIMS, Best Research Paper Award at Annual Conference IAN 2001, and 8th International Sardar Patel Prestigious Award 2013 for Neuroscience Research. He has been membership to professional bodies like IAN, NSI, IEA, API, ISA, WSO, IACM. So, welcome, sir, to this program.
Thank you.
And our next moderator is Dr. Parul Dubey, who has finished his MBBS from GR Medical College JA Hospital and MD General Medicine from Gandhi Medical College and Hamida Hospital, Bhopal. She has finished DM Neurology, SMS Medical College and Bangur Medical Research Center, Jaipur. Currently, she is working as a consultant neurologist in Manipal Hospital, Goa, and her major achievements are she has been an associated editor of the book A Clinician's Approach to Neurological Disorder. She has been speaker and faculty in many conferences like National Neurology Conferences in 2014-15, Neurological Society of India in Coimbatore for acute encephalitis and Hyderabad for brain tumors, Shine Chennai for movement disorder case session, and Enter Kolhapur for electrophysiological basis of EEG. She has been a contributor in the most prestigious reference book for neurological specialties, headache subsection, Yearbook of Neurology and Neurosurgery 2012. And she has also co-authored two chapters in the Guidelines for Vertigo Management in India in association with Elsevier, IAN Clinical Guidelines on Vertigo Management in India 2013. She has 20 publications in national as well as international index journals, and she has also presented a poster on cerebral venous thrombosis, a study of 106 cases in the European Stroke Conference, London, May 2013. So, welcome, Dr. Parul Dubey, ma'am, for
Thank
this
you very
session.
much. Thank you.
Thank you. Next is our first speaker of the session, Dr. Mandar Vagralkar. He has finished his MBBS, MD Medicine, DM Neurology, FINR, that is Fellowship in Interventional Neuroradiology, EDSI, European Diploma in Ischemic Stroke Intervention. Currently, he is working as consultant and head neurology and neurovascular intervention in Care Hospital, Nagpur. His major achievements are awardee of Young Investigator Award at 15th Stroke World Stroke Congress 2023 Canada, awardee of Observer Fellowship INR from Thomas Jefferson University, Philadelphia, USA, awardee of CREF Educational Grant at World Live Neurovascular Conference, Rio, Brazil, awarded gold medal in DM Neurology in August 2021 from Udaipur, Rajasthan, awarded certificate for best postgraduate resident in the batch of 2014-17 at KLES JNMC Belgaum, Karnataka, secured second position in aphasia quiz in the single theme workshop continuing medical education and continuing rehabilitation education held at Udaipur in March 2021. He has also got certificate of merit for achieving second in clinical medicine quiz at 71st Apicon 2016 at Hyderabad. He has almost 15 papers in national and international journals and has presented multiple papers and posters across various platforms. So, welcome Dr. Mandar Vagrelkar for this session.
Thank you.
The second speaker of our session is Dr. Somya Ranjan Pradhan. He has done his MBBS from Medical College, Kolkata, MD in Medicine from Windsor, and DM in Neurology from SCB Medical College. He is currently working as consultant neurologist at Ashwini Group of Hospitals, Bhubaneswar. His area of interest are neuroimmunology, stroke, and epilepsy, and he has been a life member of IAN and NAO. So, welcome, Dr. Somya, to this session.
Thank you.
Okay, and with that, I am not sure if Sir has joined. Otherwise, I'll hand it over to Sir if Sir has joined. Dr. Ichapuri. Otherwise, we can start with
I
our
think we
first.
can go ahead with the first presentation. As I mentioned, Dr. Ichapuria is currently in an emergency, so he'll be joining us alongside.
Yeah. So, Dr. Mandar,
Yes, you want me to share my screen?
yes, Dr. Mandar. It's just below on your screen, share screen.
Yes. You able to see my screen?
Not yet.
Just hold.
Yeah, we can see now.
Can you see now? Is it full
Yeah,
screen?
yeah, we can see.
All right. Yeah. Good evening, everyone. Good evening, moderator. I'm Dr. Mandar from Nagpur. I'll be presenting one short case which I recently encountered in December 2020. Basically, the case is quite complex to me, at least, and secondly, it's the case. It is the case is himself a doctor. He's a physician who had to me with the stroke symptoms. So I'll start with my case. uh, just before starting the case, there are some disclosure that its financial and social economic constraints do play a vital role in our settings, and a regular patient follow-up in at least on our setting is a huge challenge, despite the patient himself being a doctor. So coming to case, he is a 54-year-old male with a past medical history of hypertension, cardiac disease. He underwent PTCA. There was no LV dysfunction when he presented to me in the first visit. He was on Ecosprin 150 and he was compliant. There was no addiction history. And he was found to have left-sided weakness with dysarthria in the morning of during December 2023. He was immediately, as he was a doctor, he immediately called his colleague, and after that he was referred to me. He was rushed to ER. Our code brain was activated. As you can see in the CT scan, we also had advanced imaging, perfusion imaging. In this CT scan, we can see there was an old chronic infarct involving the left MCA territory. Was this side he presented with a right MCA territory infarct, and the CT angiogram, as the brain and neck vessels showed, there was significant proximal M1 MC occlusion involving the on the right side. We immediately rushed him to a mechanical thrombectomy. There was a right M proximal M1 MC occlusion, as you can see on the DSA picture on the AP view as well as lateral view. Yeah, and he immediately underwent ticket 2C recanalization. The artery was opened up. The clot was not hybrid, I could say, because I was present during the mechanical thrombectomy. The clot was mostly a very soft RBC rich block. It was not a hybrid rich block, which would have tell on at least on the visible eyeballing itself. And there's no procedural complication after that. So he was evaluated what was the cause of the stroke. Routine blood parameters were within the normal parameters, and his 2D echo showed ejection fraction of 50%. There was mild apical hypokinesia, but there was no clot involving LV, LA, or LV, and there's no chamber enlargement during that time. So he was started on dual antiplatelets, ecosprin 150 and clopidogrel 75 mg. We routinely don't check for clopidogrel resistance. We usually prescribe patient initially on clopidogrel when starting dual antiplatelets, and he was discharged with a minor residual deficit. He was quite improved. NIHS went from high to low during the time of discharge. So he was stable for approximately 6 months. He resumed his work. He started having doing his OPD work and everything. Uh, Suddenly, after 6 months, he developed acute onset confusion, an episode of GTCS followed by altered sensory. Whenever we encounter a stroke patient presenting with a GTCS, the first thing, whether it's like the Taltz palsy or whether the patient has a major vessel occlusion involving the ICA, internal carotid artery, or the posterior circulation itself, because he had presentation acute onset confusion state, and it was witnessed actually by the staff of one of his staff. After 6 months, he was immediately again rushed to ER. On examination, he had Broca's aphasia. His right side power was 3 in the upper limb and 4 on the lower limb, and left side was residual weakness because of the last stroke he had 6 months back. NIHS during that time was around 6 to 7 ish. I could have said. So he was shifted to MRI immediately. On MRI, we can see there were small infarcts involving the left region, high posterior frontal cortex region in the precentral gyrus, as well as in some in the left insula also. And on the right side, you can see the old gliotic infarcts involving when he had last time. So on the angiogram, what could you see? There was a mild to moderate narrowing involving the distal M1 MCA, left MCA, but there was no vascular stenosis in the major of the arteries. Even the neck angio was completely fine during that time. As the NHS was around 6 to 7 ish, so we thought we'll decide whether to thrombolize him or whether to take him directly to cath lab. But he was thrombolized as he was in window period itself, and the NHS was more than 3. There was partial improvement in his speech within few hours. So we thought we'll not take him for the diagnostic angiogram. So that during that time, what we thought, what was the most likely etiology? Initially, he had presented on the right side, now on the left side. Whether it's cardioembolic, last time the echo showed just a mild apical hypokinesia, and he had ejection fraction of 40 to 50%. There was no clot. Whether we are dealing with the vasculitis, whether it's a hypercoagulable state, there's no comorbidity apart from major risk factors like hypertension and diabetes, but it was controlled. They were not uncontrolled. He was very well compliant with the medication. And whether we need more workup. So that's what we thought during that time when he had a second stroke. And we thought we discussed with the majority of the even the intervention radiologies, because he was himself a doctor, so we had to involve 2 3 neurologists, senior neurologists also with us, and 2 3 radiologists also were, and even cardiologists were obviously, because his colleagues were cardiologists, so they were also involved in this. So we thought we'll do a Holter monitoring, we'll do transthoracic as well as transesophageal echocardiography. We can do a vasculitic workup also, and whether a hypercoagulable state evaluation, whether it's required or not, that was also dealt with based on pros and cons, and whether we need all of them. So every point of further line of investigation was discussed in detail with the consultant as well as with the patient. uh, because this time he had presented with GTCS, we thought we'll just do a EEG in this. And this time the EEG in the ICU, because he was in the ICU, showed left temporal sharp activity. Unfortunately, I don't have the image to show you. This is the report we could have taken out from the EMR. So there, and we advise for the long-term EEG because we are not certainly showed that he didn't have like a sharp, very spiky activity in the EEG, but definitely there was a left temporal sharp activity. Just to rule out any temporal lobe involvement, we thought we'll do a long-term EEG on follow-up. His serum homocysteine was 10.9, which was normal. Viral markers were negative. Cardiac markers, this time we repeated again they were in normal limit. And again, 2D echo was repeated. It showed a kinetic apex only and ejection fraction of 50%. This was a 24-hour loop recording which showed a baseline sinus rhythm. There was no paroxysmal events. There was no signs of any paroxysmal atrial fibrillation or what. So he was this time he was started on injection Clexane, enoxaparin zero point 0.6 BD during the admission, and he was discharged on acetron 2 mg between the INR of 2.1 and ecosprin 75. This was which switched. Initially, he was on ecosprin and clopidogrel. This time now we assume that is a multi-territory in fact involving both the vascular territory. We thought it might be hyper cardioembolic, so we consult the family as well as discuss with the cardiologist that we whether it's better we start and anticoagulation, that is acetron 2 mg or clopidogrel. So when you think that everything can, what else can go worse? Whatever happened in this case, it had happened. So he presented within 48 hours again to the ER with another episode of GTCS, followed by persistent right-sided weakness. We had already started him on anti-epileptic also, along with acetrom and ecosprin 75. So this was his NIHs was high. His GCS was E4, M5 status. Again, right side was what one in the upper limb and lower limb was three. Persistent left gaze preference was there. Initially, we thought whether it's a bleed because we have started on anticoagulation also, and he was shifted immediately, urgently to MRI. Just the possibility of Toll's palsy with the bleed. We had to rule it out. This time there was a large diffusion restriction area involving the left MCA territory, predominantly in the insular region, parietal temporal region, also involving the external watershed area and as well as temporal lobe. This was the perfusion imaging, which showed there was a significant penumbra, which was deficient, and he had to undergo mechanical thrombectomy. This was the angiogram, showed a left M1 MC occlusion, and the carotids neck imaging was completely fine. And as you can see, he had underwent mechanical thrombectomy on the right side in the first setting, which the vessel seems to be perfectly fine, and there's no significant atherosclerotic, or you can say other comorbidity changes in the neck angio. This was the DSA pictures. Left M1 occlusion. I can see he underwent TK2B recanalization. During the procedure, this time we had a small dissection in the petrocavernous ICS segment during the procedure, which was dealt with preferably, and he was put on Onyx Resolvent 4.5 by 25 stent across the dissected segment, because we thought we'll wait for the sometimes after giving anticoagulation, but the artery was closing off on off. There was no vasculitic changes suggestive. There was no bedded appearance, but we had to place a stent during that time. But the vessel was open and we had significant good results. Echocardiography again after 6 months showed apakinetic effects in the third setting of stroke. Ejection fraction is 45%. Rest everything was normal. There was no clot, and there's no other significant abnormality we can see. And every time the echo was repeated by a senior cardiologist in our hospital. This time we switched him on tablet dabigatran 110 mg twice BD and a ticagrelor 90 mg twice daily. There was partial improvement in his aphasia after the mechanical thrombectomy post 48 hours, you can say, and the risk of bleeding complication was explained to the family because we were giving ticagrelor as well as dabigatran 110 mg this time. So he was stable for 2 months. But there was no history of any TI, no history of any GTCS or seizure. He was again fourth time brought to ER with the one episode of dizziness, shuffling, and fits. There was no limb weakness or seizure-like episode this time at the fourth episode. So on examination, he was good M6. Residual aphasia was there due to previous stroke. No facial involvement. The power involving all four limbs were 4/5, and the pupils were normal. This time on the brain imaging, we see another small embolic like infarct involving the left MC territory, high frontoparietal region. And on the neck imaging, we can see 3D reconstruction image which showed a stent artifact. So there's nothing. Both the arteries of the MC are well opened. The carotids are fine. The collaterals are sufficient. So there's nothing significant on the rest of the angiography imaging. This was the fourth stroke event which we had on the left side. So this time we again repeated EEG whether there is a temporal lobe involvement, which we had seen in the last time. There was no such involvement in this time. We did sometime long-term EEG involving both the sleep as well as awake state, and we repeated a thoracic echo this time again, which showed again the left mild akinetic septum as apex as well as the ejection fraction of 40 to 45%. He was again, this medication was shifted. He was started on injection Clexane 0.6 BD and a ticagrelor 90 mg twice daily. He was discharged this time without any new residual deficiency, right? So we started from ecosprin and clopidogrel, then came to ticagrelol, then we switched him to Clexane as well as ticagrelol 90 mg BD. So what can go again more worse again? So he was stable for again 2 months. Fifth time he had episode of GTCS, which was witnessed by his wife and brought to ER in the post-ictal state. Forebrain again was activated. We knew he's the patient. He might again have had stroke. So this time there was a significant perfusion deficit on the right side, which we had on the first image. So this time, after having two strokes on the left side, now he's having stroke on the right side. Again, on the angiogram, there shows a right proximal M1 MC occlusion, and an angiogram you can see that there's definitely a IC occlusion. Left internal carotid artery cannot be visualized because there is a stent artifact, but the MCA is quite open, as well as the AC artery is flowing, and you can see a small atherosclerotic plaque involving the left vertebral artery proximally. So we went ahead for mechanical thrombectomy as NIHS was high, IC occlusion was there. This was the APA lateral view of angiogram. We had used this aspiration thrombectomy. Initially, we opened up the vessel, went ahead again. There was a small clot right in the right and the proximal M1, M2 junction. Again, it was aspirated with the mechanical thrombectomy, and the procedure went well. There's no intraprocedural complication. So after having a 5 times stroke in a different territory settings, what will be the further line of investigation? Whether to repeat a Holter monitoring, whether to repeat a TE or transthoracic again, the hypocarabolic state workup, whether to do a PET scan, because he had some prostate issues, but it was not significant. We thought we'll screen up the paraneoplastic workup also, whether he had some to rule out malignancy also to prostate of everything. So all of them we thought which was discussed in detail, and we'll go ahead because is having recurrent stroke in a multi-territory setting. We again repeated the echo. Transthoracic echo showed again ejection fraction of 45%. No, there's no evidence of shunt. TCD was again done. TCD was not actually initially was not done. We repeated this time, which showed no evidence of any shunt, and repeated Holter monitoring for 48 hours, which showed no evidence of paraxonal AF. We also repeated D-dimer this time. He had a history of COVID. So we thought we'll repeat a D-dimer also, which was 2084. Peripheral smear, which was normal, normocytic, normochromic, and his serum calcium level was 8.4, which was normal. We repeated a vascularity as well as detailed ANCA-CNCA workup also. ANA was done by FA, which was negative. We repeated a detailed vasculitic workup involving a different antigen, which was also normal. Because he had some gastric issue, the gastric surgeon advised to just to do a biopsy whether we are dealing with any paraneoplastic conditions or paramalignant syndrome. So the biopsies also came to be normal. It did not show any evidence of malignancy. We also underwent, he was a doctor. He also insisted on detailed workup this time because this was the 5th time. So FDG PET was done involving whole of the body, which showed some enlarging query lesion involving the prostate gland on the right side. Further, we thought we'll do a PSA levels also. By the time the PSA report come, we'll correlate along with this involvement. The PSA level came to be normal. Again, we were in the dilemma that whether we are dealing with a paramalignant condition or not, paraneoplastic. So this time he was discharged on injection Clexane 0.6 BD and clopidogrel 75 mg once a day. There's no recurrence of symptoms since then, and we are hoping for the best. So the question again still remains: what will you do, or what will another patient comes with the similar symptoms? Whether we do the same settings what we followed, whether we do again long-term loop recorder like seven days, whether we repeat a TE or transthoracic again, follow up with a D-dimer and work up more for the paraneoplastic syndrome, or just we pray that and he should not have another stroke. Thank you.
Thank you, Dr. Mandar. Is Dr. Ichapuria there? Okay. Mandar is very, very interesting case, and Dr. Paul also is there. Very, very difficult 54-year-old man having recurrent strokes for 5 times.
Yes.
And the only investigation he didn't do is for SCSF examination, which otherwise you have done everything else at your disposal, because primary CNS vasculitis may have all other investigations normal except the
Yes, sir. We
CSF
thought of it, sir,
examination.
but
Yeah,
we
you
discussed
were
with
not
family.
thinking in those lines, but you thought of vasculitis, but
Yes.
you didn't think of primary CNS vasculitis. But these recurrent illnesses are coming. There's no headache as such.
No headaches, sir. No headaches,
There's
sir.
no headache throughout, and
Wow.
he has got hypertension, and he also has coronary artery disease, underwent
Yes.
PTCA. So, I
Yes.
mean, there is a underground atherosclerotic background going on possibly.
Yes.
So it's not that all our medicines will completely cure everything and prevent
That's what
everything.
we were thinking in ground of ESUS, sir, embolic source of because new papers and guidelines
Yeah.
are coming in line of ESUS.
And
So that,
seizures are usually with stroke or cardioembolic, usually by and large.
yes,
So loop recorder, maybe up to 3 months, 6 months is in order.
yes,
And maybe we don't know whether any medicine which can prevent or which can control the heart rate for paroxysmal AF could have helped in prevention of this, because
right,
his LV diameter, and there is a dilatation, there is a the ejection fraction is going down slowly, about 15-45%.
right,
And usually we give anticoagulation only if it is more than 30 or less than 30 of ejection fraction. But you started quite early, around 50 also you
yes.
started. So this is a very tricky. Unfortunate, he's a medical man. Dr. Paul, you can give your
Yeah,
comments.
yes, sir. Uh, Thank you for this very interesting case, Dr. Mandar, and I really pray that such a case does not come to me. So a few things that went through my mind as you were presenting. One was there was no history of fever at all, right?
Hold on.
Uh, During the entire
Entire
history.
course, no.
Yeah. And another thing is sometimes because blockages are happening in different
Okay.
territories in bilateral hemispheres, whether vessel wall imaging would also
Might
be,
we discussed that also, ma'am. So we are kept
yeah,
the same what sir said, including the CS
yes,
and vessel warm imaging.
yes, CSF, and yeah, that was what
I
I was
think
thinking. Yeah,
intravascular, the DSA might miss most of the time because we don't know how the morphology of vessel wall is because
yes,
we are actually
yes,
being inside the vessel and not the vessel wall. So might
yeah.
it's
Yeah, so that is one thing that came to my mind
right,
because vessel wall imaging helps many times to distinguish between the vasculitis and RCVS patterns also. And he did not have any substance abuse or
no,
drug
no,
abuse,
no,
things like
no,
that.
no habits.
Yeah. Uh, One comment also I want to make is that I had presented a case once long ago in which there was such a case who came back again and again, again and again with strokes, and finally we found herpes zoster associated vasculitis. So doing workup for that uh,
Right, right.
also might be a good idea because that patient then finally had responded to steroids and
Okay,
acyclovir.
right.
So, yeah. So in recurrent strokes, that's one thing that I would keep in mind. Another thing, once I think on this same platform, we had discussed a case in which they had done a cardiac MRI
Cardiac
because
MRI.
there's some ejection fraction happening 45%.
Yes.
So, okay, one thing that I wanted to ask was why did you start him on acetrom on the second? Because usually nowadays, either we would go with the
Well,
NOAC or
work or something because there were like many complex issues. So he was himself a physician, and there was two, three cardiologists, senior cardiologists involved. So
And
it
Dr.
was
Mandar,
more of
you are
a
correct. There is no recommendation for starting Novox
yeah,
in these countries. It's only for paroxysmal atrial fibrillation associated.
correct.
Evidence based, if you ask.
Yes, sir.
People
Yes,
can give any time right and left. But there are four conditions which we have to think. One is the mitochondrial disorders which can have recurrent strokes. And of course, hyperhomocystinemia you have already considered. And how is the hemoglobin? Is there a sickle cell anemia that is causing?
no, sir. No, sir. We
Right.
require
Then
the detailed.
Fabry's disease is one of the things which will have Fabry's disease, but rightly younger individuals,
Okay,
maybe not for case, because
right.
that is one of the things which is crossing my mind. The
Yes.
secondary cause of CNS vasculitis, as Dr. Parul is saying, you have already done for viral etiologies. I think you said there are
The basic viral markers were negative.
viral markers were
So the
negative.
detailed, I didn't do a PCR studies or CSF
Right.
test.
Because he's failing anticoagulation. Every time you give
Yeah.
an he's failing. So that
Yeah.
means the only thing that can help him is steroids or
Yes. Yeah.
immunomodulation. Yeah. So that's what is not been tried. So it is better we do a CSF examination and see if primary CNS vasculitis, if CSF is positive, you don't require anything else. If you get
Yes.
an active, so you can start him on steroids and it might help.
Yes, sir. But
So
it's been 4 to 5 months now, sir. He's been on injectable anticoagulation.
Flexi.
hmm.
And he did not have he actually started walking without any support. Now he's independently doing his OPDs. And the thing is, we had initiated him on oral acetrom also, and we actually initiated him on the newer generation anticoagulation also. Both time he had strokes, so we thought we'll give him
And
injectable also.
prothrombotic workup also we didn't do, no? Because you couldn't do because it's
It was
already always
already
on oral
started.
anticoagulation.
Already started. And we did not have a chance to like stop it and wait whether another stroke should happen and evaluate in that terms. So
But how long? How long can we give Flexane like that?
so yeah, I asked him to come next month and do a reevaluation because it's already been 6 months. Initially, we thought he wanted us to give for the initial 3 months. We thought, but it's already going on. And he because he consulted one of the two, three cardiologists and neurologists in Delhi as well as in USA. So the same history was presented to him, and most of the neurologists suggested him that he should be on injectable anticoagulation. And I asked him because he did not show two three like two three follow-ups were missed.
As long as platelet counts are favoring, he can do, but
Yeah, that is favoring, sir.
that's
But only thing is the
it's
etiology.
not working. The problem is it's not working. You're giving the anticoagulation, but there's no use. There's something else is happening, which is beyond our comprehension at this stage. It could be paroxysmal AF, and you may require to do a rate control or medicines. And
For primary CNS vasculitis, what I feel there has to be some changes in the vessel wall because we had
sure,
detailed angiograms were done DSA.
yeah, because the positivity, I mean, the specificity of even brain biopsy is not that. Even DSA is not that much in
Yes,
that.
yes,
And one Ames, I was doing a CPC, and actually that twice they did biopsy and they missed. They have been having recurrent strokes.
okay,
Final diagnosis was primary CNS vasculitis in the end. But
right.
here there's a multi-system involvement. There's already, I mean, one more system and it will become multi-system because cardiac and neural are involved usually in atherosclerotic. If you
Yes.
have anything else which you can do biopsy, and that will help. Neuropathy, has got any neuropathy?
No, sir, no, sir. No neuropathy. Only he had some small symptoms suggestive of small fiber neuropathy, but we had repeated now conduction study. There was no evidence of any
Because small fiber you won't get in nerve
no
conductions. You'll have
conduction.
to do biopsy. You
Yes.
have to do either lip biopsy or
No,
skin
sir.
biopsy.
Biopsy we had, but he refused for the biopsy.
Hmm.
Like more invasive tech because he had already been through a lot
Hmm.
during 4 to 5 episodes
So
of.
it is not ICAD. No, it's not ICAD because
No.
there's nothing which is fixed,
I,
right?
that's what I think we thought of thinking of in terms of emboli. Some
Hmm.
of emboli he's having, and it has
It
to be
must be
treated.
coming from heart only, no? Because
Yes,
progressively that is getting affected.
yes, sir. Only the anterior circulation.
Yeah,
No stroke involving the posterior circulation in
so
any
far.
time. Yes, sir.
And as Dr. Parul said, we pray to God that we should not get such cases and God should help him to. Because, see, doctors have their own limitations and we
Yes,
all should agree to that. And we should say that, yes, we are at our wits' end now. And we can only, as you say, pray that he will not get anything and be happy with the medicines what you are given him. But next time, I think you should consider CSF.
definitely, sir.
CSF is must. At least if you work for 2 3 days, stop all the anticoagulation and everything.
Yes,
I think we should go.
definitely.
I think.
Dr. Mandar,
Yes,
okay, can I ask a
No,
question, sir?
yes, yes.
no.
Yeah, fundus was normal
Fundus was normal, sir.
and APLA was negative.
Yes, yes.
And just I wanted to know for my own because I'm not an interventionist. How many times can we do this thrombectomy MT again and again?
And we can do every day. If patient has to every day.
Okay, all right.
Already once dissection has taken place. See, it is not that it's a safe procedure always, but you have already caused one small problem for him. And
Yes,
yeah,
yes.
so
But it was a higher notch stroke, and we had to intervene.
No, it's no. You did the best. That is at your disposal. Yes.
But please consider zoster because that one case has stuck in my memory. Maybe.
Definitely. I'll definitely discuss with
Thank
Okay.
you.
Thank
All
you.
right then. Thank you very much, Dr. Mandar. It's indeed a pleasure listening to a wonderful case, and
Thank
we
you.
pray to God that he should not get any more episodes.
Thank you, sir.
Welcome.
Thank you. Wonderful case.
Thank you.
Organizers, you can take over and call the next case,
Yeah.
please.
Oh, yeah, over to you, Dr. Soumya. The share screen is just below. If you can see the green color icon, share screen.
But Soumya Pradhan is from Bhubaneswar.
Yes,
Yeah.
sir. I'm from Bhubaneswar.
Yeah.
There is any issue, then maybe I can present it from my end. Okay.
Yeah.
Right,
You can see. Just
Right.
if you can make it full screen. Yeah. Yeah.
Is it visible now?
Yes.
Yes. Good evening, respected moderators. Respected director, sir, is not available, I think. Myself, Dr. Somarendra Pradhan, I am a neurologist practicing in Bhubaneswar. I am from Ashwini Hospitals. Before I begin, I will like to take few moments to express my sincere gratitude to Dr. Nasli Ichapuria, sir. Last year, he was with us in a workshop in our institute for a workshop on neuroradiology. From behalf of our institution and from my managing director, Dr. Maya Gantat, who is a famous neurologist in our state, we'd like to thank sir for his continuous support to us. So let's begin with the case. This is an interesting case with an interesting presentation. So I have chosen this case for this platform. This is about a 56-year female who is a housewife by occupation, right-handed, and history was taken from her son. She presented with to us with acute onset tonic-clonic movement of left side of body and twitching of left side of face for 1 day, and it was associated with altered sensorium. Before presenting to us, her symptoms had started since 2 months. She had developed abnormal behavior in form of irritability and aggressive behavior. She started shouting at family members without any obvious reasons and sometimes with filthy languages. Sometimes she would laugh out loud without any reasons. For 1.5 months, she started forgetting things. She was unable to find her daily routine object like keys, clothes. For 1.5 months, she hallucinated as if someone is talking to her. For one month, she had developed urinary incontinence. For these symptoms, her son took her to a psychiatrist for obvious reasons, and she was treated with antipsychotics. These symptoms did not improve even after taking antipsychotics, so she was admitted in a local private hospital. While undergoing treatment, she developed tonic-clonic movement of the left half of body, followed by GTCS. Thereafter, she had presented to our hospital. There was no history of any blackout, palpitation, or abnormal sweating, RBD, any fall, slowness of activities. There was no history of any double vision, blurred vision, headache, vomiting, limb weakness, jaundice, fever, joint pain, rash, oral ulcer, or chronic diarrhea. She was a diabetic for 1 year and was on metformin 500 milligram once daily. She was not a hypertensive. There was no history of any stroke in past. There was no history of tuberculosis, seizures, or CKD in past. She was married, diet history was normal, and there was no history of any addiction. No family members had similar illness in her family. Coming to general examination of this patient, patient had normal blood pressure and pulse. There was no pylorictus, cyanosis, clubbing, or lymphadenopathy. JBP was not raised, and general condition of skin, hair, and nail was normal. Since patient was in altered sensorium, we did a brief nervous system examination. GCS was 9, Pupils were both in normal in size. Pupillar reflex, both direct and conceptual, are present. Meningeal signs were absent. Plantar was bilaterally non-responsive and reflexes were 2+. So summarizing this, patient 56-year female presented with insidious onset, progressive psychiatric disturbances, cognitive impairment for 2 months, and acute onset focal to generalized seizures for 1 day, followed by encephalopathy. So with this, the differential, we approach this case, the differential coming to our mind as a neurologist, the first should be autoimmune encephalitis, since she was a young female and which started with psychiatric disturbances followed by seizure, typically involving face and unilateral limbs, facio-brachial seizures, typically LGI1, NMDR, or anti-GABA or anti-AMPA. Next should be infectious encephalitis. Any slow-growing space-occupied lesion next should be it in our mind. Early onset neurodegenerative disease like early frontotemporal dementia or early Alzheimer's disease can be a possibility. Some metabolic causes like Hashimoto or any vascular causes like repeated vascular dementias can also present like this, but there was no past history of stroke. So with this differential, we investigated this case and managed this case. First, since she was she had presented in a status, so IV cannula was inserted and seizure was controlled with IV lorazepam and loading dose of IV levetiracetam. After giving lorazepam and levetiracetam, the seizure was occurring, as you can see in these videos. She was having focal seizures involving the left lower limb. In this video, this facial seizure involving the face. So facio-brachial seizures were continuing, so we had to add second anti-seizure medication, that is lacosamide. After addition of lacosamide along with levetiracetam listed by lorazepam, the seizure was controlled and patient was seizure free. So we did basic investigations. TLC was mildly raised, maybe because of this UTI. Hemoglobin, urea, creatinine, sodium, potassium, electrolytes, parameters were normal. LFT was normal. Thyroid profile and transthoracic 2D echo were normal. Then the EEG. The EEG only showed delta slow waves without any sharp or spike waves. We did NCCT brain. As you can see, there were bilateral basal ganglia calcification, and in the cerebellum, there we can see dots of calcification involving the cerebellum. In the sections involving basal ganglia, as you can see, there are periventricular hypodensities along with a gliotic change in the left basal ganglia, probably old in fact. Similarly, in the this image, there is an old infarct in the left parietal area. Since we're suspecting autoimmune encephalitis, we did a ECSF study. The cell count was normal, protein was elevated, sugar, ADA, CBNAT, gram stain, which later came to be negative. CBNAT came to be negative, and culture later came to be negative. With this, we did the MRI of this patient. The HWI sequence, as we found in CT scan, these are bilateral symmetrical hypointense area corresponding to the calcification. Similarly, in the there is a bilateral symmetrical hyperintensity involving the subcortical area and a black dot, as we can see in the cortical subcortical junction. In the T2 image, there are periventricular white matter symmetrical hyperintensities. Now coming to DWI, now there is an acute infarct in the left occipital area. In the basal ganglia area, there is no acute infarct. Probably they are the old gliotic changes present bilaterally are probably old infarcts. In the T1 weighted image, there are similarly hyperintense lesion corresponding to bilateral basal ganglia calcification. Now coming to FLAIR images, as we can see, there are bilateral fascica grade 3 white matter hyperintensities along with glyptic changes in the bilateral basal ganglia, and there are hyperintensities in the temporal area along with left occipital area. Since the autoimmune encephalitis was still in our mind, we did anti-TPO antibody, which was normal, and NA profile, the vasculitis workup we did were negative. We also did autoimmune encephalitis antibodies panel. All the antibodies like NMDA, LJ1, AMPA, AMPA2, CASPA, GABA-B, all were negative. Patient had bilateral basal ganglia calcification, and patient had presented to us with seizures. So we did the calcium metabolism panel, calcium, phosphorus, and parathormone, all were normal. So parathyroidism cases may present with hypoparathyroidism cases present with basal ganglia calcification, with seizures and psychiatric manifestations. So we did the calcium metabolism workup, and it came to be normal. Now, what is it? So if we revisit our neuroimaging, there is, as I said, bilateral basal ganglia calcifications are there, and the cerebellum dots of calcification involving dentate nuclei, maybe involving the dentate nuclei are present. So is it, are we dealing with familial brain calcification because it presents in the fourth or to fifth decade, and it presents with neuropsychiatric symptoms, movement disorders, and seizures of various types can occur frequently with genetic involvement of PTGFP and PTGRB. Or are we dealing with something else? If we revisit the MRI, this as we can see, there are Fascica 3 white matter hyperintensities, and there is involvement of external capsule, and the anterior temporal lobe is also involved. So are we dealing with small vessels disease? So we did a genetic workup for this patient. Whole exome sequencing was sent, and to our analysis, it came to be NOTCH3 mutation in exon 4, and which was pathogenic. So it is
Actually, that was what I was also thinking, because temporal lobe hyperintensities are seen. It's a CADASIL type.
Yes.
Yeah.
Yes, it is a, sir, it is a, because patient had not presented the typical symptoms. She had presented with seizures. And as we know, CADASIL generally present with headache, migraine, transient ischemic attacks, and repeated strokes. But the presentation was different. So, and the first, the presentation was within a history of span of 2 months with a faciobrachial seizures. So the first thing, as I
LG1.
as I thought to be, it is an autoimmune encephalitis involving faciobrachial seizures. But eventually, when we investigated this case, CT did show calcification involving the dentate nuclei and basal ganglia. So the thing that was in mind, that has been
calcium metabolism.
Yes, calcium metabolism disorder. So that was the confusion that was occurring. After MRI brain, the things were clear, but there was no family history. So we did a genetic workup, assuming that we will get CADASIL. So it came out to be CADASIL, sir.
Yeah.
So we can, it is a most common cerebral hereditary small vessel disease, and characterized by non-atherosclerotic and non-amyloid diffuse angiopathy involving small to medium-sized arteries and leptomeningeal arteries. And in 1996, NOS3 was identified as the cause of CADASIL. As we go into the history of CADASIL, first in the year 1977, the initial report of hereditary multi-infarct dementia was identified. And in the 1993, the first definition of CADASIL and mapping of disease locus to chromosome 19 was done. Identification of NOS3 was done in 1996. Till 2023, reports of over 350 NOS3 mutation have been identified as a cause of CSPT. As we know, the core manifestations of CADASILs are migraine with aura, TIAs, and recurrent ischemic strokes, psychiatric disturbances, cognitive impairment. But But uncommon manifestation of CADASILs are epilepsy, intracerebral hemorrhage, Parkinsonism, and deafness. And in our case, the patient had presented to us with seizures. So seizures occur in only 5 to 10% of CADASIL patients and rarely as an initial or early symptom. And what is the mechanism of seizure in this patient, in these patients who has a subcortical pathology? The exact cause is currently unknown, but high signal intensity lesions frequently found in on anterior temporal region may be associated with epileptogenesis in these patients. Cholinergic neuronal damage along white matter tracts may generate seizures. These are all postulated theory for mechanism of seizure in CADASIL. So we treated the patient symptomatically. The patient was discharged with oral anti-seizure medication and aspirin 75 milligram daily. She was on trials tube. Although the aspirin role of aspirin is debatable, but I still prescribed the patient with aspirin 75 mg daily, and she was seizure free. She had slight improvement in her sensorium with GCS of 11 at the time of discharge. And this was sir with our senior neurologist of Odisha during his visit to Odisha with his radiology colleague, Dr. Yogesh Lahar. And thank you. Thank you for your patient hearing.
Thank you, Dr. Soumya. Dr. Ichapriya, sir, are you there?
Sorry, sir.
Dr. Ichapriya has come, joined us? No.
No.
Dr. Soumya,
So I think he's still in an ICU due to an emergency.
That's Soumya, it's very interesting case and very well worked up and worked up the case. One thing, some interesting aspects have come up about small vessel vascular disease in 2024.
Yes, sir.
So this called I think last trial where they started using isosorbide mononitrate with cilostazole as the combination that is proven to be more effective in preventing small. I don't know whether, because aspirin also debatable in this case, but whether you should go about that combination to prevent further episodes is one of the interesting things that occurs to me. Dr. Parul.
Dr. Soumya, quite an unusual case.
Yes,
Yeah. And a very good presentation. I mean, you have worked the case up completely. Um, does this is basal ganglia calcification described in CADASIL anywhere?
Yes, I have searched literature, ma'am. Somewhere in 1 to 2 articles, they have mentioned it is found, but though there is no sufficient evidence that I could describe you, ma'am. So I have not linked the interest classification with CADASIL.
So it was just an incidental
Finding.
I think so.
yeah, yeah.
But it has led him to do a lot of calcium investigations.
Yes. Yeah.
One will end up doing all this, and you are trying to, because it's a rapidly progressive condition. Rapidly progressive dementia will
Yes.
come into differential diagnosis, and you are rightly considered all the possibilities.
Yes, sir.
And everybody would have thought of anti-TPO and NMDA receptor antibody and VGKC, and all these things will come.
Yes.
And your protein is slightly raised in CSF.
Right.
Cellularity is not there, and right. So
Yes.
these are all indirect indications.
Yes.
Very well worked up. Any other questions you can answer? Forum? I don't know. The administrators to tell us. Anybody can interact and raise questions.
So
So
currently,
yes, we do have a delegate link, but currently there are no questions on the delegate link as such.
Okay, then Pratiksha, then I think we should thank profusely both the presenters. They have done excellent job and very good cases, and a lot of learning exercise for us, and a lot of memories have been refreshed. I think Dr. Parul, you were closing comments.
Yeah. So I have been enriched today by these presentations. Congratulations to Dr. Mandar and Dr. Soumya for enriching us. Really, I always learn a lot from these sessions. Thank you so much. And thank you to Dr. Ichapuria sir, who made me a part of this program. Thank you, Gorti sir. It was very nice to be here.
Right, right. And it's indeed a pleasure interacting with all of you. We miss Dr. Ichapuria's exuberance in this presentation.
Yeah.
Otherwise, you would have definitely added flavor to the proceedings in the evening today. Dr. Pratiksha, thank you very much for calling us for this presentation.
Yeah.
Okay, then.
Thank you, everyone. We can call it a day.
Good night.
Thank you.
Okay.
Good
Thank you.
night.
Good night. Thank you.
Bye.
Recording stopped.